Hi, my name is Connie Koklanis and you're watching the video 6th Cranial Nerve Palsy Management. In this video we will discuss the non-surgical and surgical options for managing a patient who has been diagnosed with a 6th nerve palsy. Commencing with non-surgical management, as you're now familiar with, three of the main options we have in terms of assisting the patient with their diplopia is providing them either with prisms, occlusion, or assisting them with an abnormal head posture. So in terms of prisms, because 6th nerve palsy is caused an esotropia, you'll always have a base out prism to prescribe, and you could do this either as a full prism or a sector prism. Now, in relation to 6th nerve palsies, it's lateral gaze that's affected, so either right gaze or left gaze, and as such you'll be blocking one of those positions of gaze depending on whether you have a right lateral rectus palsy or a left lateral rectus palsy. As an example, if you use a sector prism for a right lateral rectus palsy, you would need to put the sector on the right side where the right lateral rectus has its field of action. Occlusion would be the same. If you put a sector occluder or sector occlusion on the glasses, then what you would be looking at is blocking right gaze and giving the patient single vision in that position. In terms of the abnormal head posture, as we've noted in the previous video, we'll be looking at turning the head right or left depending on the palsy that's present. And to the right there we have an example of a child with an abnormal head posture that's relatively large. It might be okay whilst you're waiting for spontaneous recovery, but certainly that would be not a long-term abnormal head posture that the individual could sustain. You would need to operate to bring that patient's BSV into primary position. The other option in terms of non-surgical management is injecting botulinum toxin. We've discussed this in the principles of managing patients with incontinent strabismus, and it's particularly utilised in 6th nerve palsies. And what would happen is, as you know, the medial rectus would be injected as you have a lateral rectus palsy, and by injecting the medial rectus, you will paralyse this muscle and effectively straighten up the eye. Now, this can provide temporary re-establishment of BSV for the patients, depending on how successful the botulinum toxin is. And in children, it could even prevent suppression and amblyopia. The problem we have with injecting the medial rectus is with a recently acquired 6th nerve palsy, it will interfere with your ability to monitor progress and improvement of the patient as you've paralysed the medial rectus. I've also mentioned in the previous videos that there is some suggestion that by injecting the medial rectus you could prevent contracture of the medial rectus. This is relatively controversial and the evidence isn't strong in supporting this. So there are ophthalmologists who will do it for this purpose, but there are also ophthalmologists who do not believe that injecting the medial rectus will prevent contraction. So we'll have to wait for the evidence regarding that as to whether it is or isn't effective in achieving this. The other option we have is to inject for the purposes to assist someone to maintain BSV. This is useful usually in patients who have a small residual ET that's relatively concomitant, and for some reason the patient just doesn't seem to be able to utilise their fusional divergence to take control of the ESO. And it appears that by injecting Botox into the medial rectus, giving the patient a BSV for some period of time seems to assist them to lock onto that BSV, and once it's worn off, they hold on to it and they maintain binocular single vision beyond Botox. So it's a really good option to trial this prior to going into surgery where you have residual concomitant strabismus that's stable. Okay, let's move on to surgical management. So in terms of surgical management, we're going to consider once again the muscle sequelae and look at operating on the muscles involved in the muscle sequelae. So let's assume a right lateral rectus. So here we have a right lateral rectus. It's weak, it's palsied. So one of the options is to strengthen this extraocular muscle. Then we have the ipsilateral antagonist, which is overacting. There is contracture of this muscle. So we can look at recessing this. The contralateral synergist, the medial rectus of the left eye, is overacting, so we can consider weakening this muscle. and then we have the lateral rectus of the left eye, which is the contralateral antagonist. Now, often this muscle isn't operated on, but it could be, and if you were to operate on this muscle, because it's an underacting muscle, it would be a strengthening procedure. Okay, the last thing I have there on the list is to transpose functioning extraocular muscle tendons to the lateral rectus. So we'll talk about this in a moment, but essentially where the lateral rectus is totally paralysed, there is no way to get additional abduction to that muscle by strengthening it. You need to take the vertical extraocular muscles, transpose them to where the lateral rectus is to gain function or to gain abduction. We'll come back to this in a moment. When considering or planning for surgical management of patients with a sixth nerve palsy, there are two main elements that need to be considered. First, where is the field of greatest deviation? And so we're looking at, is the patient concomitant, or is there a field of gaze where the esotropia is greater? And secondly, is there any residual lateral rectus function? So we're talking about, is there a total paralysis, or do we have a paresis that's partial? I'll take you through how to decide what type of surgery to do in either of these instances, or when you consider these particular factors. But before we do this, I want to mention one more thing. The medial rectus, or the ipsilateral medial rectus, I should say. I've mentioned a number of times now that we need to make sure that there isn't medial rectus contracture, because this will effectively limit abduction. Where you have contracture of the medial rectus, so it's found that there is a tight medial rectus, it must be recessed. So this is one of those decisions where if the patient is in theatre, there may be a couple of options that the surgeon has in terms of how they might operate on this patient. And if they find that they have a positive force duction test, they will actually recess that medial rectus. The issue is that if you didn't identify that the medial rectus was tight or was contracted, then the procedure you perform on the lateral rectus could actually give you an unexpected result, because you may be assuming that there is total paralysis or close to total paralysis, or much more underaction of that lateral rectus than there truly is because of the tight medial rectus. So surgery may be undertaken on that lateral rectus and is more than required. So this is why it's really important to work out, is there contracture of the medial rectus, recess that medial rectus, and take that into consideration when you combine that with any other muscle surgery. Now, moving to determining whether there is a field of gaze where the deviation is greatest, and if not, what do we do? So essentially we're looking at competency. Does the patient have a concomitant deviation versus do they have an incomitant deviation? If they have a concomitant deviation, so the esotropia in primary position, right gaze and left gaze is relatively the same, then it is safe to resect the lateral rectus and recess the medial rectus. We will do unilateral surgery as we would with any other patient with an esotropia that's concomitant. The only thing to consider here is that if you have a relatively large angle strabismus, you may need to do 3-muscle or 4-muscle surgery, which means moving over to the left eye and operating on the medial rectus and or lateral rectus of the left eye. Let's just have a look at the image down below here. If we take a look here at the lateral rectus, if we resect this muscle or strengthen it, we'll have an impact in primary position, and also we'll have an impact in left gaze as this muscle, in right gaze as this muscle acts in right gaze. Now, in terms of the medial rectus, by weakening this medial rectus, we'll have an impact in primary position, and we'll also have some impact in left gaze. So essentially, we're trying to achieve a similar effect on the ET in primary, right gaze and left gaze. Now, the other consideration is, do we have a partial palsy or do we have a total palsy? Let's start off with partial. Now, there are two categories here. We could either have good function or fair function. Now, good function is generally when you're seeing a -1 and possibly a -2, but we're looking at about 80 to almost 100% function on that lateral rectus, as opposed to fair, where we're looking at about up to 50% of function, so you're looking at about a -3, maybe a -2. So there's obviously an overlap between good and fair, and depending on the surgeon and the orthoptist, they'll determine whether, by their experience, they feel there is good or fair function there. Let's start off with good function. Where you have good function of the lateral rectus, it is best to avoid resecting the lateral rectus, so strengthening the lateral rectus that's palsied. The reason is that if you resect it, you can create a mechanical restriction in the opposing direction. So as an example, if you were to operate on the right lateral rectus and that was palsied, but it has good function, then as the patient adducts their right eye, you could find a limitation in right gaze. This is similar to the discussion we've had regarding superior oblique palsy surgery. Remember, if you tuck the superior oblique, you run the risk of having a Brown syndrome. So you have a risk of mechanical restriction in the opposing direction where you'll cause limitation of elevation in adduction. So in avoiding the lateral rectus, what we'll do is we'll do bilateral medial rectus recessions. We can do the contralateral medial rectus. Let's say we've got a right lateral rectus palsy. This would mean operating or weakening the left medial rectus, the contralateral synergist, and we can also recess the ipsilateral medial rectus. Now, we would often do, where there's incompetency, more surgery on the contralateral medial rectus than the ipsilateral medial rectus. The reason is, let's take the example again of the right lateral rectus palsy. When we operate on the left medial rectus, it will have more of an effect in right gaze, and that's where we want the greater effect. So if there is incompetency and the deviation is smaller in left gaze, you want to do more surgery on the left medial rectus than you do want to do on the right medial rectus. Okay, where you now have a fair amount of underaction of the lateral rectus, you can go now and resect it. So here we will often recess the ipsilateral medial rectus and resect the ipsilateral lateral rectus. So recess, resect, or unilateral recess, resect. The other thing you can do is also move over to the contralateral medial rectus, which has an action in right gaze if we're looking at a right lateral rectus palsy. This will give you an added effect, and also what you can do is do this procedure with a posterior fixation suture or perform it with a FARDEN. I'll talk to you more about this in a moment, but in essence what you're doing here is you're trying to get little effect in prior position and most effect in the position of gaze of the acting muscle. So if the contralateral synergist is the left medial rectus and you put a posterior fixation suture on this eye, what we'll see is more of an effect in right gaze. Some textbooks will also talk about simply doing a resection of the lateral rectus and a recession of the contramedial rectus. Now, in doing that, you're targeting the two muscles that work together in the position of gaze where you have the greatest size of the deviation. This is appropriate as well. And is often done where there's no contracture of the medial rectus. However, if you do have contracture of the medial rectus, you will need to recess it. And finally, the patient with the total palsy, so where there's no function of the lateral rectus or there's very little function of the lateral rectus. In this instance, we have to transpose vertical muscles to the lateral rectus to gain some abduction. I'll take you through this in a moment. But I'll just also mention that in some instances, those transposition procedures are also done with a recession of the medial rectus. So the medial rectus is often contracted in this particular instance, so you'll recess this and also perform a transposition procedure to gain some abduction of the palsied lateral rectus. Now let's just have a look at the image here to the right to summarise what we've just been discussing. And let's assume a right lateral rectus palsy. So the right lateral rectus is palsy, and our option is that we can strengthen this lateral rectus and weaken this medial rectus, and we'll have the greatest effect over here in right gaze. However, if the lateral rectus is functioning relatively normally, then by tightening this muscle, we will have a limitation in left gaze, and we want to avoid this. So in this instance, we want to go for the 2 medial recti. Also, if we have total paralysis of the left or the right lateral rectus, then we want to actually transpose part of or all of the superior rectus down here to the lateral rectus and the inferior rectus up here to the lateral rectus to allow it to gain some abduction function. And a reminder that when you find contracture of this medial rectus, you must recess it so that you can gain as much function or abduction function as well. Okay, I just want to spend a moment on the posterior fixation suture, which is also called the Farden procedure. Now, in this particular instance, we can see here that this is the posterior fixation suture. So what we're trying to do is put a suture on the extraocular muscle that we're operating on and shift the effective insertion of the muscle. And the aim is to produce a progressive weakening of the eye into the field of action that it operates in. So if we say, for example, that this is the left eye and this is the medial rectus, then by putting the posterior fixation suture on the medial rectus, there will be little effect in primary position, but progressively the posterior fixation suture will have an effect on adduction of that eye. And before we move on, I just want to bring your attention to transposition procedures that have been mentioned just a moment ago. So where we have a lateral rectus that is paralysed, has no function, we need to move the vertical rectus muscles or transpose them to the lateral rectus to gain some abduction. Here I've listed 4 procedures that can be done. There are several others, and the choice of operation is often surgeon preference. Well, let's just have a look at a few examples. Here we have the whole muscle transposition, where we see the superior rectus is transposed 1 full muscle length towards the lateral rectus, and the inferior rectus also transposed. This will gain or allow the eye to be able to abduct. Here we have the Hummelshine procedure, where the superior rectus is halved and the lateral half is transposed towards the lateral rectus. And here again, inferior rectus is halved and transposed to the lateral rectus. The Jensen procedure is similar in that we actually halve the superior rectus, but now we also halve the lateral rectus. And so this half of the lateral rectus is sutured with the superior rectus, and this half of the lateral rectus is sutured with the inferior rectus. And finally, the Foster augmentation procedure, which we have similar to the whole muscle transposition. So a whole muscle transposition is done here, but also there is a suture that's placed above and below the lateral rectus to the adjacent vertical rectus muscles, as we can see here. Okay, so all these procedures will have an effect in assisting the patient to be able to abduct the eye. And finally, the bilateral 6-nerve palsy. These are difficult to manage successfully because you have a large impact on motility, and these patients generally don't have any area of BSV, and it would be very difficult to achieve BSV in all positions of gaze. The best thing to do with your 6-nerve palsy is to stage the approach, and this would mean looking at performing surgery on one eye, or for one particular palsy, I should say, and then operating on the other once you see what the outcome is from the first operation. So you would usually operate for the palsy that's greater. So if you have a right lateral rectus palsy and a left lateral rectus palsy, and the left lateral rectus palsy was worse, you would operate on the left one first. Sometimes you will gain a good result from just that single operation, but you may need to go back in again depending on the situation and the outcome. In terms of the procedure selected, you will utilise the principles we use for unilateral 6 in the consideration of surgery for bilateral 6. So in summary, in terms of non-surgical management, we obviously have our options are prisms, occlusion, abnormal head posture in relation to diplopia. But Botox is also a good option in sixth nerve palsy, so consider this as well, depending on the situation. In terms of surgery, there are a few things that we need to consider when planning to operate on a patient with a sixth nerve palsy. Firstly, you need to consider whether you have a medial rectus contracture, in which case, if there is a positive force duction test, you need to recess that medial rectus. You need to think about, is it concomitant or incomitant? This will influence the surgical choice. Is it total or partial? And finally, do you have a unilateral or bilateral sixth nerve palsy? So in considering all those factors, you'll be able to plan for surgery. And just note that surgical decisions can often be based on surgeon preference and their experience. So what we have in this PowerPoint may not reflect every surgeon's preference or choices, and you may come across also textbooks that discuss other alternatives for sixth nerve palsy procedures, or procedures for sixth nerve palsies. Okay, that brings us to the conclusion of this video. Thank you for watching.